Let me introduce Professor Lakshmi Lingam, who will be chairing the lecture and the subsequent discussions. Dr. Lakshmi Lingam is a professor at the Tata Institute of Social Sciences. During the period from 2011 to 16, Professor Lingam was the Deputy Director at the Tata Institute of Social Sciences in Hyderabad. Her research interests range from exploring the social and gender-specific implications of health sector reforms and other macroeconomic policies, studying women's movements and other social movements in the era of globalization, and understanding women's health and reproductive rights. She has published extensively on gender, health and development. Dr. Lingam was the Indo-Shastri Visiting Scholar associated with the University of Montreal, Canada in 2011. She is a 3-time Fulbright Fellowship holder. Dr. Lakshmi Lingam is on the curriculum advisory boards of several women's studies departments in Indian universities, as well as on technical and ethical advisory boards of NGOs. Dr. Lingam was a member of the National Resource Group of the Government of India Mahila Samakhya Program for Women's Empowerment under the Ministry of Human Resource Development. I invite Dr. Lingam to take the session.
Invited me to chair this session. I always enjoy being part of these initiatives and also part of these conversations. I don't have any problems about anybody calling me at short notice, because I think it's extremely useful to have the kind of connections that everybody should have, especially if they are in academics. And personally, when I introduce myself to my students or I introduce myself in various fora, I always say that I'm an individual who has one foot in the women's movements, one foot in the women's movement and one foot in academia. And I think both are equally important for us, because both are arenas of politics and feminist politics. So I really look forward to this evening. So I call upon the speaker for the day and the chief guest, Professor Simone Diniz, that's how you call yourself, please. I probably would go there and speak, but you could come and sit here for a while. Okay. I'll just make a few preliminary comments. Professor Diniz is an associate professor at the School of Public Health, University of Sao Paulo, Brazil, and she's also a visiting reader in women's health at the King's College London. Her education is in the area of medicine and public health, and she has long years of experience teaching, researching, and I find that practically all the papers have a connecting thread of looking at childbirth, looking at birthing, looking at women's health, and the human rights concerns that are very central to all these aspects of women's lives. And she's on various networks. She's also a founding member of various networks, and I find myself connecting to her so well, because she's in the academia and has her foot again in the women's movements in Brazil. So welcome, Simone. You're a wonderful sister. YMCA for us, this particular place, is very important and very historical from the point of view of the women's movements. And I see here several young people who have come in, and I must say that this is going to be a long journey, and welcome on board. I have come in the 80s to one of the meetings here at YMCA when we were talking about sex-selective abortions, the right of girls to be born, and how do we understand medical practices that actually are going against the lives of women and the women's right to be born. And we were also talking about how do we look at issues of regulation, at the same time make friends with doctors who are actually going ahead with these technologies in a very competitive manner. So the entire campaign on the right of the girl child and the issue of sex-selective abortions almost kick-started here, and many of us who are PhD students came in to sit here and listen to people like Manisha Gupte, Malini Karkal, Padma Prakash, many friends from the feminist movements talking so eloquently and making so many connections to data, so many connections to ground realities and also public policy. So most of the time we had to take care to see that our jaws are not dropped, to hold back and see. And I think attending those meetings, being part of those conversations became extremely important for us to sharpen our own understanding about what is feminist politics all about. It is about how we deal with these issues in our classrooms. It is about how do we communicate about it. It's about how do we conduct research so that we carry forward that particular strand of thought with all the academic rigor that's required to make that point very well, to be able to make a difference in public policies and also continuously have those connections with women on the ground. And many senior women like Renu Khanna, Sundari Ravindran, Leela Visari are great women in this room who have done that and still very modestly sit back to let go somebody like me to speak. And I really learn each time I come for these meetings. So I really look forward to your session. And then we have three discussants who will again come, and two or three who would come and give their reflections on the experiences in India. And to say that I think at each point of time, Indian feminist movements have continuously engaged with the state, because the state is the biggest provider of healthcare services. So willy-nilly, whether it has to do with population policies, whether it's to do with long-acting injectable contraceptives, whether it's to do with things like regulating the kind of medical technologies that are coming in place. Practically, the Indian feminist movement has always been kept on its toes to, in a way, work with the state and also counter the state in all its various activities, which are sometimes pro-women and sometimes anti-women. So our attempts to now start looking at safe deliveries and also making sure that human rights of women at the time of birthing, and also alternative practices, also reclaiming our traditional birth attendance, all these are very much on the women's movement's agenda in this country, but probably we have still so much to learn, and we look forward to hearing from you. Thank you. Do you want to really go and stand behind that, because you're going to just disappear?
Yeah.
This is a podium that's been done keeping a height of 6 feet man in consideration. Most of us are not. Of course, Sangeeta could reach that, but I don't think others can. So maybe you take this and somebody can operate your PPT and you can sit and talk or stand here and talk, whichever. This mic seems to be very good.
Professor Chandra Barbindan for inviting me to come to India. It's such a pleasure and an honor to be here, and I have learned so much these few days that I'm here. And especially I was talking with Sangeeta, and I'm very impressed with this new generation of feminists here, but also people of my generation, even more senior than I am, and very impressed with how the situation that we face in Brazil is so similar, although we have very different situations. So I'm very excited with the many opportunities for collaboration that we may have with our work here in India, both academic collaboration, but also collaboration with women's movements and learning from each other. I think that I would like to share with my colleagues what I'm learning here. So I will try to. Let's see if it's working. Yes. Okay. Very well. So I'll tell you a bit about the movement for humanization of childbirth. And I was very much impressed about how we can think about ways to collaborate and to promote change in the case of our several settings. I'd like to tell you a bit about Brazil, tell you a bit about where the humanization movements comes from, the relationship between humanization, evidence-based care, and human rights, a bit on the data of last survey on childbirth in Brazil, The new interpretations of biology of childbirth, especially the issues of epigenetics, microbiome, I will just give you a notice on this because I think that this is the future and this is very important to dialogue with the women and with providers, and especially the issue of medical education, the issue of maturity of birth, and the fact that in Brazil we have the shortening of the duration of pregnancy and the effect that this has in the offspring. And thinking about humanization of care and what would be the gold standard of childbirth care, pregnancy, and postpartum in this century. So Brazil, it has, in terms of population, has 1/5 of the population of India. You know, we are a very young country. I was comparing this and talking to Sundari, our colleagues in Kerala, because you have centuries of history and we are relatively recent. But we have so many differences and similarities that I'm strongly inviting you to come and visit us. We do have organized an exchange program. One of the most interesting things that happened in Brazil in the last decade and a half is that we, compared with the other BRICS, we are the most unequal country, but we had a very sharp decrease in inequality and increase in income in last decade. But we are in a very difficult political and economic situation presently in Brazil, and this trend has been, you know, there's a threat of being reversed. In terms of gender distribution, we have more or less half and half. We have more boys being born in Brazil, just a little bit. We have very little of this problem of the difference in gender sex selection in Brazil, including for adoptions. Girls are much more preferred than boys, so what we have, this difference reflects the high rate of violent death in the male youth in Brazil. And like everywhere else, the female population is larger in the older ages. So to talk about the context, in Brazil we have universal health care and universal coverage, and health care is part of our constitutional rights in 1988. We have a national health system that consists in 3 subsectors: the public one, that's provided by federal, state, and municipal levels. Each part contributes with 1/3 of the funds. We have a private non-profit that are usually also the public buys the service of this private non-profit, and the private profit that's related to insurance, but the direct purchase too. And the public sector in Brazil is free at the point of delivery and attends about 3/4 of the population. But the part of this service are contracted out of the private sector. So we have direct services, public services, and public service, free service provided but bought by the state to the private sector. So this constitutional right to universal health care is strengthened by the present government. These pictures of yesterday demonstrations and confrontations of the police because they were voting the withdrawal of this constitutional right. So we are in a very difficult political situation presently in Brazil. This is a tear gas and, with the demonstration yesterday. So in terms of the millennium goals, you were talking about what we had until 2015, we had a very sharp decrease in infant mortality. We reached the millennium goal in 2011, but the perinatal component is the one that is very resistant to change. It's very much related to quality of maternity care. So in terms of maternal health, we have the fertility rate is very similar to the Indian one. We have a very important drop in the fertility rate. It continues to decrease in Brazil. It didn't stop to fall. Access to antenatal and birth care and the health facility also increased. We have around 98-99% of institutionalized healthcare, including remote areas. But our cesarean section is very high. It's 36% overall population and over
85% in private sector. We have even cities that have 100%. People say, no, this is logistically impossible. No, not in Brazil. We have cities with 100% of cesarean section. I will tell you how this is possible. In maternal mortality rate, it has been stagnated for the last 20 years. And how is this possible when you have universal health care, universal antenatal care, and so on, is one of the main research questions that we have presently, you know. We say that the optimistic people talk about maternal mortality rates stagnant, you know, but if you look closely, there's a very clear trend in increase in maternal mortality, which is not happening just in Brazil. Many countries are seeing, especially developed countries, are seeing an increase in maternal mortality rate. It is due to the increase, the better reporting and so on, but it's not only this. It's an increase of intervention that is related to this. But we have hypertensive disorders, sepsis, hemorrhage, complication of abortions as the main cases. But we have lots of misclassification of the maternal death. We are presently dealing with the decrease in our capacity in our maternal committee in terms of the investigations of cause of death. You know, this is one of the main concerns that we have. And we have illegal abortion in Brazil, and around 1 million unsafe abortions a year. What are the barriers to decrease maternal mortality, neonatal and perinatal mortality too, because they are very much related. The quality of maternal and child care services is variable. Frequently it's poor. We have very high rates of unnecessary obstetric interventions. You know, the same that was previously mentioned in the episiotomy. We have 40% of fundal pressure. You know, we have augmentation and induction with oxytocin liberally used. We have many interventions that some of them, when used advisory, they can be used, but you know, it's kinds of oxytocin can be used, you know, in a very controlled way, but using the way it is quite a safety problem. One of the most important safety problems both for neonatal and for maternal health. We have poor integration between antenatal and childbirth care despite this high coverage, so lots of problems related to reference and country reference. And we have the frequent what called pilgrimage between hospitals. So women were supposed to be referred to one hospital. There is a hospital that she was supposed to go, but frequently there's no place there, and then she's sent everywhere else. Sometimes she's not admitted because she has risk. So because she has risk, she had to be admitted, but instead she goes up and down, you know, looking for a place, sometimes in labor, which increases risks and so on. And the other problem is the role of medical the central part participation of doctors. You know, the lack of greater participation of midwives and nurses, especially for women who are low risk. So this is one of the problems, but we have some increase in nurse midwifery training and direct entry midwiferys and a whole program about birth centers. This is a whole political struggle related to this. So, let me tell you a bit about humanization of childbirth, this movement. This is a plenary of the movement, you know. In recent Brazilian history, women had a strong engagement against the military dictatorship. They were very present on this, and also organized the union syndicates, and they were the forefront for the political amnesty, for the fight for direct election, because we had indirect election for 20 years. And also there was very important influence of international feminism, especially for women who were outside of Brazil. I was telling the colleagues, you know, about this film called She's Beautiful When She's Angry. I don't know if any of you saw, it's a documentary about, any of you saw this film? You should. It's wonderful. It starts with in 2014, but goes back to the 60s and the 70s, and we can never retire from feminism. It's very interesting because it puts together the new generation, of feminists, and it's the influence of these movements. What they had in Brazilian health feminism. For instance, I was part of this feminist collective on health and sexuality, and we were very much influenced by the Boston Women's Health Group Collective, the Dispossessed Farm in Geneva, and by several other groups that were challenging this medical status quo and trying to empower women to deal with the health issue. There was a very strong movement in the 80s against violence and against honor killing in Brazil, and this led to the creation to the several public policies. And as Lakshmi was saying, we always try to dialogue with the state because we want public policies. So there was a creation of policies such as the police station, and so in the 80s they started the creation of this council for women's status, and some within the state, some organs dealing with public policies for women. And this movement had also a very strong participation in Brazilian health reform and all the struggle for universal health care that we. And part of this was the idea of the integrality of care. That means that not only primary, secondary, tertiary kind of care, but also biological, psychological, and social health, and also for women, not only what we call maternal-infantilism, because everything was very restricted to pregnancy and childbirth, and that was all, sometimes a bit of cancer, but putting together a broad agenda on women's health. So in 1983 there was the creation of this comprehensive women's health program that was called the PAIS. There was a lot of struggle related to this, and there was a very broad agenda, including everything: sexuality, sexual diversity, race issue, violence against women, a critique to medicalization, self-help, mental health, aging, not only women in reproductive age, but from childhood to aging and so on, menopause. Everything was in the agenda. It was pre-Cairo, pre-Beijing, pre-sexual and reproductive rights, but these concepts were very much present and they were very much incorporated in the agenda of the PAIS. So there was a very strong focus on public policies, on creating public policies, and the issue of childbirth was always there from the beginning as one of the most important issues. By that time, in the 90s, there was the start of having a very strong critique on the form that women were treated during pregnancy and childbirth especially. There was several research in Brazil showing the amount of violence that women faced in childbirth. And there was also the emergence of the Cochrane collaboration, the group, the pregnancy and childbirth group of the Cochrane collaboration. I was telling in the sessions that we had with Sundari, I was showing the story of the Cochrane collaboration and the role of the pregnancy and childbirth group with the Oxford Perinatal Epidemiology Unit in organizing the methodology that Cochrane has, and building the foundation was the embryo for the Cochrane collaboration. And these were two of the products of that process: the Guide to Effective Care in Pregnancy and Childbirth, and this red one, which is a publication by WHO that has 20 years. That's a Care in Normal Birth, a practical guide. It's an incredibly useful guide. And women start to say, hey, this is the evidence, this is why we're having a care that's not evidence-based and so on. So people were putting together the idea of women's rights, human rights of women, and the notion of the need for evidence-based care, and having this guideline and so on. So we use very much the idea of innovation in public health. I will give you some examples like relactation, kangaroo care, and changing childbirth settings, etc. It all came together with the idea of humanizing, using appropriate technology, using a framework of the rights of women and children. In this change, there was a lot of resistance to have this care that's better, it's safer, it's cheaper, etc. So these moments of change led to the creation of this movement, and in 1993 there was the foundation of the network for the humanization of childbirth. So this is a network of very diverse providers, health activists, researchers, feminists. It's a very different composition of to deal with the smallness of change and resistance to change. So in the recent years, there were a lot of other social movements around, like the midwife. We resumed the training of midwife, university midwife, direct entry. There was the movement of doulas. There was whole movements of partners, new providers, etc. Yesterday we had the last day of the conference, the International Conference of Humanization of Childbirth. That was in Brasilia, in the middle of the demonstration that will be in Brazil. So there's this active movement. We have we meet every year, every 5 years there's an international conference, and it's very active in terms of promoting public policies. More recently, we have these new narratives, and I'll tell you a bit about these new narratives. Especially that we had in this century, especially in 2005, we had the creation of several networks of women, especially the one called the Parto do Princípio Network. That's one that's very devoted to the issue of violence against women in childbirth. And in Latin America, several countries have typified obstetric violence and created specific legislation related to this. There was a very important research done by the Pessoa Foundation that it was a population-based survey that included for the very first time the issue of violence against women in childbirth. And it was amazing because it was almost all the interest that press and people had was about obstetric violence because it was a new issue. And then it had the first estimate, populational estimate in 2010 that 1 in 5 women reported being abused during childbirth. So there was also the establishment of International Initiative for Respect of Childbirth Care, the White Women Alliance, who is having a lot of international initiatives. I strongly recommend people can join the alliance, people can be part of their mailing list and be in touch with many initiatives. I'm very glad to know about this meeting that's going to be about human rights in childbirth here in India, here in Mumbai in February. Yeah, so there's going to be all people there. In Brazil, these last 3 years, we had public hearing about obstetric violence. We had obstetric violence corroborated videos. It was very much consolidated as a research project. This is one of the posters of the so-called public hearings that was done by the public prosecutors in local places. So all around Brazil we had these public hearings, and they were extremely important, because they put together the people who are responsible for women's health in the health department, the responsible for medical training, everybody, the directors of the maternity services, with women's movement, and women would make the narratives of the violence they have suffered and talk together about how to overcome this. It was so powerful because we began to have lots of very concrete solutions and monitoring with deadlines to be implemented and so on. This happened because many of these women that were lawyers and judges in the public prosecutor, they got pregnant, and then they started to study about this, and they realized the level of violence that they were supposed to go through. So they became very much activists on this. So in Brazil we created a slogan. This is a scene that's it's called the birth cinema. You know, you have you book elective cesarean, a buffet, the transmission. It's a whole party. Of course, birth has to be elective, and people celebrate the birth of by a C-section. So. One of the great motivations to have a C-section is that you depend on have an aggressive, violent birth. So cesarean section is the way to escape this kind of nightmare that is non-evidence-based, full of intervention kind of childbirth without companions, immobilizing the dichotomic position with a episiotomy, with a thermal pressure, and so on. So the slogan is no more stop violent births delivery to self-C-section, because we think that there's a name, a finality of having a violent birth is to sell this kind of commodity. So recently we had this new initiative like the Mother Baby Friendly Birthing Facilities Initiative. We are piloting, that's what I'm discussing with Sundaria, and we very much want to collaborate. We are doing an intervention based on this initiative. Very much trying to tailor it to our reality with a very participatory approach into training hospitals, because training hospitals are the worst of all, and training facilities are so conservative. Medical schools are very conservative, very gender biased. The books are very biased, so we are trying to refresh this a bit with this investigation. And we are finding a lot of support from the medical training people, and we'll be having a lot of allies. This has become a very important research subject. This is a very interesting paper. The amount of paper that's being published is amazing. It's a tsunami of very good papers about you could call it obstetric violence, abuse and disrespect, or many other things. We did a mapping of the terminology, and it's very extensive, but calling the global epidemics of abuse and disrespect to childbirth. So the history of this initiative, and there are many innovative approaches to this. One of them is the idea of this harm-free care, because it's a general issue that we think that we have to trade off our bodily integrity, our emotional integrity to have a child, It's for Christians, it's very, I don't know, it's here for people from other religions, but Christians, it's our myth of creation that God said you have to suffer to have children and so on because you ate the apple. It's not the whole story, isn't it? So we don't believe this, we believe in a God that's much more generous and woman-friendly. So we believe that most women could go through childbirth in one piece without compromising bodily integrity. The childbirth could be a much easier experience. It's not that women do not have the right to choose, It's a whole other debate. Not everybody agrees with what I'm saying, but I think that women have the authority to choose, in this situation. But we need informed choice, and we need options, because completely we don't have. This is one thing. And it's not that women sometimes need intervention, we should have no fundamentalism against medical intervention, Just have to use them wisely. But we have the right to harm-free care, So one of the most interesting initiatives is the sacred thermometer. That's an initiative about the NHS. So anyone who wants to know more about this can go to harmfreecare.org. That's very interesting. And they use for general care. There are 4 indicators for general care. It's pressure ulcers for urinary infections in patients with catheter and venous troubles embolies. And there is a maternity safety thermometer, which is a resource, can be done in 10 minutes, very easy. And safety is wonderful tool. Nobody can be against this, It's excellent to estimate the temperature of care. So you can go also to this website. There's a lot of things. It's very interesting to collaborate. We are piloting also the safety thermometer. They have, this is general data of the women, but the indicators are bodily integrity, if we have the perineal trauma or abdominal wound, postpartum hemorrhage and how to estimate, because there's a whole problem how to estimate, infection, the baby's outcome, and whether the woman's perception of safety, that's to be asked to the woman. So I strongly encourage you to know more about this because this is very important. Also, in terms of the new narratives, I'm very enthusiastic. I teach this, I teach at this basic public health, but also part of this basic biology, in perinatal period. And I strongly suggest this new interpretation of the biology of childbirth are extremely important. How the childbirth itself, going through labor and having a proper birth, is important to set up all the epigenetic turning in and out of the genes that we need to healthy fetal to neonatal transition. So this is a very important book that was recently published that summarized many of these issues. I won't go into detail to this, but it's the idea of childbirth as a neuroendocrine epigenetic microbiome formation process with impact for the rest of your life, because it changes everything that we understood about the physiology of childbirth. This is very, very important. The role of the hormones, all the hormones, including the stress hormone, but oxytocin, endorphins, and so on. The different impacts in the baby and in the mother. This changes the idea of the routines and ambience because they have not been aimed at facilitating physiology. Women need tranquility, comfort, safety, privacy for a healthy birth. So how this new knowledge can orient us to change, how services are organized. And also, regarding this, the news interpretation of biology, I will insist on this because I think that medical and other health professionals training has to change to incorporate this because this is the future. I think that there are very important consequences for the baby of the different modes of delivery in the short and long term. Let's repeat that well-educated cesarean section is very important resource and medical care is very important. However, its excess is the problem, and women have the right to inform a choice. This is a gender issue. But let's accept also, we also all the time in the narratives, women have to submit themselves because of the sake of the baby, otherwise she will kill the baby. And everything that's good for the mom is good for the baby, This, in terms of physiology, we can affirm this. But when you think about C-section, especially non-medically indicated, elective C-section, in the short term, you increase the chances of preterm delivery, low birth weight, difficulty in breastfeeding, bonding, etc. But in the medium to long term, we have increased overweight, obesity, asthma, type 1 diabetes, allergy, metabolic dysfunction, and many other non-communicable diseases. These epidemics are very complex and depending on many other things, the kind of food we have, the sedentary lifestyle, structural problems, etc. But this is one issue and a very important one. So we have populational evidence on this, that mode of delivery controlling by everything you want, increases the chances of obesity in later life. This is very important for our country that are going through epidemiological transition. This is a very important study that was just published in JAMA Pediatrics that compares the difference between being born by C-section and vaginal birth within the same family because this controls very much for both genetic and lifestyle, and the difference in the relative risk is 64%. So that's lots of evidence that we are feeling this evidence. Also for type 1 diabetes, I'm bringing here some of the meta-analysis of this recent systematic review. Those who are more interested, just Google this or get this. I can leave the presentation there, the reference, asthma and other allergic disease, many other allergic disease. These large European cohorts that was just published this year show the risk of all these rheumatic, allergy, bone disease, and leukemia. There's a very strong evidence on the risk of childhood cancer, adolescent cancer, especially leukemia. Why does this happen? So what people say, so that's different kind of microbial seeding. One of the great issues in terms of biology presently is the transgenerational transmission of the microbiome. If you Google this, you find a tsunami of papers related to this. It's because we are relatively sterile when we are born, but the first inoculum of bacteria is the one who settles down, and that's very difficult afterward to change. These several publications recently putting together how the epigenetics of labor and childbirth works together with the formatting of the microbiome for the development of the immune system, a healthy one or a dysfunctional one. And I strongly suggest this documentary called Microbirth. You can buy a license, it's quite cheap, you know, that goes into detail on the biology of childbirth. This is very important because in this recent survey that we had also the other problem is the issue of maturity at birth, you know. So we had this huge increase in C-section, and the line, you know, the trend follows the preterm birth, you know. We have an increase in preterm birth, which is higher in wealthier women, you know. The more educated women have more chance to have a immature birth, you know. And this has a very important impact in brain development. I won't go on this, but if you want to go to the Marshall Islands. There are other groups that are working with the so-called first 1,000 days from conception to the first years. This has very well documented consequences in the cognitive abilities of the child, you know. This is not easy to compensate afterwards. And in São Paulo, we see a trend, what is it, a left shift in gestational age. And the healthier babies lose 1 week, 2 weeks, 3 weeks, or 4 weeks of pregnancy, or healthy pregnancy, and healthy brain development is lost due to that cesarean cinema. You know, you can buy the whole pack, including have this kind of problem. So to finish. What is part of care? What would be the gold standard, the best results for the care today for healthy women? So it would be in terms of what we know is that full-term delivery. At the full term, you know that we used to think that a term as 37 weeks. It's not anymore. It's changed. You know, it's 39. Especially if it is spontaneous onset of birth, because this sign of the maturity of the baby and births that are not induced. It also takes place preferentially without the use of drugs. We don't need drugs necessarily. They all have adverse effects. We have to use them wisely when we do need it. And the mother without the surgical wound postpartum, without the C-section, without the episiotomy, and without laceration. We need to develop the skills to protect the perineum, you know, because at least there are many studies showing that at least 3/4 of women can have no surgical wounds after childbirth, which makes postpartum much more comfortable and so on. Prior to the physical and emotional comfort of mother and family, the technology used is the minimum compatible with safety and comfort. Comfort is also very important. This be, you know, to have women-centered, family-centered childbirth, we have to include comfort and safety. This is the point. It can be the use of technology can be done by the qualified observation. This is a challenge for us because we, as providers, we are, you know, taught that intervention is better than observation. And we can be with the provider that's more appropriate for that, you know. Technology has to be available, you know, for those who is necessary. So technology should be submitted to human needs and not the opposite as we have now. So in Brazil we're starting to see that people, you know, we always, the middle class is always the trendsetter, and people now say, I want to have the birth as a princess, you know. That means that nobody touches her, but technology was there waiting for her, you know, if necessary. But she delivered with 42 weeks, you know, of pregnancy, a large baby, in a vaginal birth, spontaneous onset, without any kind of intervention, assisted by two midwives, you know, no white, by the way. And, you know, it's now there's been a change, you know, because people are more and more informed. So I was telling, soon there is students, in Brazil we have a phenomenon now that people can read the systematic review. They know what a systematic review is, especially highly educated. And they go to the doctor and say, I read the systematic review about this and this, so I want that, I don't want. And the doctor doesn't know what is a systematic review, you know? So this is the situation we have now. So the idea of humanizing childbirth had these two components, you know, the one that is based on the human rights to you know, to be treated as a human being in this moment, and to proper care, to appropriate technology.